So, hello, dear students. Today we'll discuss about the postpartum hemorrhage. About the outline, we will discuss about the introduction, definition, and types, risk factors of PPH, causes, clinical manifestation, diagnosis, prevention, and management of postpartum hemorrhage. And the last one is the complications. So, introductions. So, during the global MMR in 2020, it was 223 per 100,000 live births. It's the reasons of the postpartum hemorrhage. Maternal mortality ratio in Ethiopia is one of the common ratings. Was 401 in 100,000 live births in 2017. 95% of all maternal deaths occur in low and low middle income countries in 2020s. As you can see, the hemorrhage is taking 24.8% of all the maternal mortality during the worldwide. Definition: excessive bleeding after delivery of the fetus that makes the patient symptomatic and or result in signs of hypovolemia. Blood loss or 500 milliliters in single vaginal delivery or 1,000 or 1 liter in twin vaginal delivery or cesarean section delivery. A 10% of decline is postpartum ACT. ACOG revised their definition of postpartum hemorrhage in 2017 to the following. It's a cumulative blood loss more than 1,000 milliliters or bleeding associated with signs, symptoms of hypovolemia within 24 hours of the birth process. Types: with primary postpartum hemorrhage within the first 24 hours of postpartum, and secondary is between the 24 hours and 12 weeks in postpartum. Risk factors: this is age more than 35 years old, obesity, grand multiparity, antepartum hemorrhage, previous postpartum hemorrhage, over destinations, it's a big baby or macrosomia, multiple pregnancy, polyhydramnios. Facultative agents when you use it before the labor, edema, connective tissue disorders, prolonged pregnancy, or some types of fibroids. Intrapartum risks is a prolonged or rapid labor, prolonged third stage, perinamnionitis, some general anesthesia, induction and augmentation, operative delivery, poorly perfused myometrium, mismanagement of the third stage of the labor. So, etiologies. It's a commonly we say about the 4 T's, but I want to present it with 5 T's. It's the last one is also the complicated of the sometimes. So first is a tone, it's a uterine atony, tissue, retaining placenta, trauma, genital lacerations or rupturings, thrombosis, it's a coagulopathy, some types of coagulopathy, and the last one is a tractions, it's a uterine inversion. Uterine atony is more than 80% of all the postpartum hemorrhage. Failure of the uterus to contract properly following delivery. Rapid uterine bleeding associated with the lack of myometrial tone. Hypotonic uterus leads to retention of the placenta and excessive bleedings. Uterine overdestination, risk factors. Uterine overdestination in intrinsic uterine dysfunction, extrinsic uterine dysfunction, prolonged exposure to oxytocin, uterine or placental abnormalities, and iatrogenic factors. Retained placenta is 10% of all the postpartum hemorrhage. A placenta that has not undergone placenta expulsion after 30 minutes of the last baby's birth, where third stage of labor has been managed actively. Parts of placenta is cotyledons, second great lobe, or fragments of membranes. Abnormally adherent placenta is maybe accreta, increta, or precreta. In this slide, you can see the tabs of abnormal adherent placenta. The placenta accreta vera is 80% adhesions. Placenta increta, it's accreta, it's a placenta increta, and the last one, less than 5% of all the abnormal adherent placenta is a placenta perpetua. This growing through the uterine wall, and sometimes it will go till the bladder or some other organs in the pelvic area. So tissue trauma is about the 20% of postpartum hemorrhage. Its location is peritoneal, vulval, vaginal, or cervical. Hematomas is a vulval, vaginal, or broad ligament. Episiotomy is uterine rupturing. Trauma is often associated with the instrumental deliveries. In this case, you can say the vulval hematoma is readily diagnosed by severe perinatal pain and usually rapid appearance of a tense, fluctuant, and sensitive swelling of varying size covered by discolored skin. Retroperitoneal hematoma, the most serious and life-threatening conditions during the labor. You can say it's a perinatal classes of perinatal tears. First degree, if we have fracturing, it's a first degree depression. We have a rupturing of the vaginal mucosa and skin. The second degree, if we have the rupturing submucosa and muscle perinatal layers, as you can see here. Third degree, if we have involving till the anal sphincter. In the fourth degree, it's if we have a rupturing till the rectal mucosa, in this case. Risk factors is a mismanagement of the third stage of the labor. It's a fatal pelvic disproportionate. We have a big baby head is in the macrosomia. Instrumental deliveries, precipitated labor, scarred uterus, large episiotomy deliveries through the incompletely dilated cervix, tight peritoneum. Thrombosis. So first of all, I also want to tell you about the rupturing of the cervix during the labor. We have three stages of the rupturing of the cervix. First of all, if rupturing in the cervix less than 2 centimeters, this is the cervix. Such imagine this is the cervix. It's the opening of the vagina in the vagina. So if we have rupturing in the cervix less than 2 centimeters, it means it's the first stage. Second stage, if it's more than 2 centimeters, but it will rupturing will don't go to the fornix, vaginal fornix. And the last one is the third stage. If we have rupturing till the fornixes, it's the third stage. So we have three stages of the rupturing, the cervix, due to during the labor. So thrombosis, it's a 1% of postpartum hemorrhage. It's a coagulation disorders. DIC is disseminated intravenous coagulation, anticoagulant therapy during the pregnancy, during the any conditions, and presence of bleeding from the other sites in addition of the genital tract, including but not limited to mucosal bleeding. Uterine inversions is a collapse of the fundus into the uterine cavity, 1 in 2,500 deliveries, incomplete or complete. Risk factors: excessive umbilical contractions, spinal pressure in the setting of a relaxed uterus, brisk vaginal bleeding in association with an absent palpable fundus abdominally. So with degrees, with first degree inverted fundus up to cervix, second degree body of uterus protrudes through cervix into vagina, third degree prolapse of inverted uterus outside of vulva, and the fourth degree is prolapse of inverted uterus and vagina, also with the vagina. Effect of hemorrhage depends on non-pregnant blood volume, magnitude of pregnancy, induced hypervolemia, degree of anemia at the time of delivery. With classes, the blood losses. First class is 750 milliliters, less than 750 milliliters. In this case, you can see a pulse less than 100, blood pressure is a normal or increase. Respiratory collapse, respiratory rhythm is 14 to 20. Capillary file is a normal. UAP is less than 13, and mental status is normal. If we have class 2, it's between the 750 till the 1,500 milliliters. So pulse is more than 100, with orthostatic hypertension. Respiratory is 20 to 30. Capillary refill may be delayed. UOP is 20 or 30, between the 20 and 30 milliliters per hour. Mental status is anxious. Class 3, it is less than 2 liters. So pulse is more than 120. Blood pressure is, you can see, is less than 60 milliliter hydrogram. Respiratory is more than 30. Capillary file is usually delayed. UAP is less than 15 milliliters. Mental status is confused. If it's more than 2 liters, pulse is more than 140. Blood pressure is markedly decreased. Respiratory colors always delayed. Anuric, we don't have any urinary. And lethargic or comatose mental status. Diagnosis is almost exclusively clinical. Consider predisposing factors, observe vaginal loss, express blood from vagina following cesarean sections. Remember, blood loss is constantly underestimated. Ongoing trickling can lead to significant blood loss. Or physical examination. So blood pressure, pulse, respiratory, polar anxious sweating, atonic uterus, again non-contracted uterus above the umbilicus. Uterine rupture, easily felt uterine defect. Retained placenta, vaginal cervical lesion. Frequent monitoring, status of the uterus is mandatory after each delivery. Always inspect the genital tract after any operative vaginal delivery and breech delivery. Prevention and management. Early risk identification, prevention, treatment of anemia, skilled birth attendance, and active management of the third stage of the labor. So, components of the active management of the third stage of the labor is a uterine drug immediately following the delivery of the fetus. Commonly we use oxytocin. Controlled contractions and uterine tone assessment and uterine massage only if it's needed. So in this case, I also want to say about the three signs that give us the signs that give us the imagine uterine is a placenta will rupture it or not. There are three signs. First of all, signs is a commonly remember only I will tell you three signs, but you will remember only one signs. So first, which is Schroeder signs. Schroeder signs is mean uterus will contracted and located on the left or right side of the abdomen. Second is the Kuznetsov signs. If you press by your hands, this part of your hands in the above of the symphysis part, you will see this umbilical cord going inside. It means placenta will not abrupted. If umbilical cord were not moving, it means placenta will abrupted and you can tract it and pull it out. And the next sign is the Alfeld signs. If you use some scissors and put it inside and put it in the umbilical cord, if these scissors will go down more than 10 or 15 centimeters, it means placenta will abrupted. In this case, you can remove the placenta fully and you will tract it and do contractions. Only in this case, you will don't have a complication like an inversion of the uterus. That's why you must checking these signs during the active management of the third period of the labor. So commonly we're also using oxytocin. It's a dosage, it's a 1 milliliter of oxytocin, have a 5 AD. So we're using 2 milliliters, it's maintain AD intramuscles after the baby head will burn. So treatment, two major components is a resuscitations and management of obstetric hemorrhage and possible hypovolemic shock, and identification and management of the uterine causes of the hemorrhage. Goals: restore of or maintain adequate circulatory volume to prevent hypoperfusions of vital organs. Restore or maintain adequate tissue oxygenations. Reverse or prevent coagulopathy. Eliminate the obstetric causes of postpartum hemorrhage. Initial management. Should follow. Initiate resuscitations. Position of the patient float. Establish two IV lines. Take blood for hemoglobin, hematocrit, or other researches. Common crystalloid infusions. Oxygen by face mask. Initiative monitoring vital signs. Consider blood transfusions if you have any indications. Treatment of actinic uterus. Uterine massage, uterotonic drugs, trexamine acid, bimanual compression, and aortic compression, uterine balloon tamponade, non-pneumatic anti-shock German, uterine compression sutures, uterine or uterovarian artery ligation, and the last one, the final one, that if you, yeah, the other treatments can help, you just do it, hysterectomy. Treatment of arterial uterus. We are using the oxytocin, ergometrin, misoprostol, or carboprost. In this case, you can see the bimanual compression and aortic compression. This bimanual compression, you will go inside of the vagina and compress the uterus between your two hands. And in this case, you can see the aortic compressions. You will press the aortic compression between your hand and the vertebra. You will press the aorta. And after this, you will don't have a blood supplying of the uterus, and we will have a less the bleedings. But you also must check the correctly you will press or not. If you press correctly, you can find the pulsation of the aorta femoralis in the internal parts of the femur. So if you don't press it correctly, you will find the pulsation. It means you must press it correctly. Treatment of atonic uterus if you're using a uterine balloon tamponade. In this case, you can see if you're using uterine balloon tamponade. And the new one is a non-pneumatic anti-shock judgment. When you're using, in this case, after the pneumatic judgment will increase, he will press, and the blood will go in the central blood vessels. That's why he will also act to reduce the bleedings in the postpartum hemorrhage. Treatment of, in this case, you can see the technique of the uterine compression sutures. It's a Berlin sutures and Hyman uterine compression sutures. We also have a uterine or uterine-ovarian artery ligations. You must do a ligation in the ovary artery, and you must also do a ligation in the internal iliac artery. If you do a ligation in the internal iliac artery, you will stop the blood supplying of the uterus. So then you will stop also bleedings through the uterus during the postpartum hemorrhage. So we also can do a hysterectomy. We have types of hysterectomy. It's a partial hysterectomy. It's a total hysterectomy. And if we remove all the parts of the uterus with the fallopian tubes and the ligaments, we call this a radical hysterectomy. Management of the primary cause is a treatment of genital trauma, treatment of retained placenta, treatment of coagulation failure, and treatment of postpartum hemorrhage after acute inversion of the uterus. So it's the management of the primary causes. So it's a treatment of the genital trauma. We will just stitching it layer by layer, and then we will stop the bleeding. In this case, if we have a retained placenta, we will remove it by our hands manually. First of all, we will call the anesthesiologist, get the general anesthesia, and only after this, we will go through the vagina and remove the placenta by our hands manually. So, treatment of the coagulation failure, we can use for anemia, transverse type specific blood. For thrombocytopenia, particularly if it's less than 50,000, we transfuse the platelets. For abnormal bedside coagulation test for prolonged PT or PTT, transfusion of fresh frozen plasma, and transfusion more than 6 units of RBC or is anticipated, give 4 units of fresh frozen plasma. And the last one is the management of the immersion. You must do adequate anesthesia in mandatory prophylactic antibiotics if the recently inverted uterus has not contracted and retracted completely, and if its placenta is already separated, the uterus may often be replaced simply by pushing up on the inverted fundus with the palm of the hands and fingers in the direction of the long axis of the vagina. Follow-up after arresting postpartum hemorrhage. Closely monitoring vital signs, monitoring bleeding and vital signs. Continue with IV fluids. Continue with blood transfusions. If patient is stabilized, assist her to initiate breastfeeding if appropriate. Treatment secondary postpartum hemorrhage is a subinvolution infection. If it's subinvolution, use the accessin. If it's infection, use the antibiotics. Retaining placenta tissue, evacuate the uterus using manual vacuum aspiration or large-sized cannula. Hysterectomy may be done if there you have any indications. Complications of postpartum anemia, blood transfusion, DIC, infection, acute renal failure, secondary amenorrhea, secondary infertility, and sterility from hysterectomy. Take-home points. Postpartum hemorrhage remains the number one cause of mortality globally. We have high burden of postpartum hemorrhage. We should consider every pregnancy as postpartum hemorrhage potential pregnancy, prevention, and early detection. Active management of the third stage of labor is the best strategy to prevent postpartum hemorrhage. A prepared team and full range of therapy is required to avoid maternal death. Postpartum hemorrhage management should be well coordinated teamwork. Thank you very much.